Shock is a life-threatening state of organ dysfunction caused by imbalance between oxygen delivery and demand. Early shock is reversible, but if untreated it progresses to irreversible damage and multisystem organ failure. Cellular hypoxia forces anaerobic metabolism, leading to increased lactate and reduced adenosine triphosphate. Failure of energy-dependent ion pumps causes calcium influx and ultimately cell death. Oxygen delivery depends on cardiac output and arterial oxygen content. Cardiac output is determined by heart rate and stroke volume, while stroke volume depends on preload, contractility, and systemic vascular resistance. Any impairment in hemoglobin, oxygen saturation, cardiac output, or vascular resistance can result in shock. Shock is classified into distributive, cardiogenic, hypovolemic, and obstructive types. Distributive shock features low systemic vascular resistance with high cardiac output and includes sepsis and anaphylaxis. Cardiogenic shock results from pump failure such as myocardial infarction with low cardiac output and high filling pressures. Hypovolemic shock occurs due to loss of circulating volume such as hemorrhage or severe dehydration. Obstructive shock is caused by extracardiac obstruction such as tension pneumothorax or pulmonary embolism. Septic shock is the most common type encountered in intensive care units. Shock progresses through compensated, decompensated, and irreversible stages. Compensated shock shows tachycardia and increased vascular resistance with minimal organ dysfunction. Decompensated shock presents with overt organ dysfunction and worsening perfusion. Irreversible shock leads to permanent organ damage and death despite intervention. Clinical evaluation begins with history focusing on potential causes such as infection, trauma, or cardiac events. Physical examination reveals hypotension, tachycardia, tachypnea, and signs of organ hypoperfusion. Cold, clammy skin and reduced urine output indicate poor perfusion. Warm extremities with high cardiac output suggest distributive shock. Elevated jugular venous pressure suggests cardiogenic or obstructive shock, while low pressure suggests hypovolemia. Shock index defined as heart rate divided by systolic blood pressure above 0.9 indicates high risk. Quick sequential organ failure assessment score uses systolic pressure, respiratory rate, and mental status. Laboratory tests include lactate, arterial blood gas, and organ function markers. Management begins with early recognition and simultaneous evaluation and treatment. 2 large-bore intravenous lines are placed for rapid fluid and medication administration. Fluid resuscitation with crystalloids is the first step to restore perfusion. Blood products are used in hemorrhagic shock to restore oxygen carrying capacity. Vasopressors such as norepinephrine are used in distributive shock to increase vascular tone. In cardiogenic shock, inotropes such as dobutamine improve cardiac contractility. Oxygen therapy targets saturation between 92% and 95% with mechanical ventilation if needed. Early broad-spectrum antibiotics are critical in suspected sepsis to reduce mortality. Shock-specific interventions include epinephrine for anaphylaxis and decompression for tension pneumothorax. Revascularization or surgery is required for cardiac ischemia and aortic dissection. The primary goal is restoration of oxygen delivery and reversal of underlying cause. Early identification of reversible causes and aggressive resuscitation are key to improving survival in shock.